Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Caramelli, and I oversee Grand Rounds for our department. I want to move pretty quickly through this today and get to today's presentation, partly because we have a little bit of a different format today. We have an introduction by Dr. Brenna Wren, initially to talk about today's speaker, but also to talk about how the research and practice presented today applies locally, what kind of training is happening locally, and other efforts that are occurring in the department. And I also want to highlight today too that coincidentally, we happen to have a presentation today occurring about a specific kind of psychotherapy. And next week, we happen to have another psychotherapy specific presentation, almost two-part. So, be sure to join us next week to continue learning about updates in psychotherapy. Just a comment on Dr. Wren. Dr. Brenna Wren is an assistant professor in the Department of Psychology at the University of Nevada, Las Vegas. Dr. Wren was formerly an acting assistant professor at the UW Department of Psychiatry here. And kept an affiliate investigator role with the Integrated Care Training Program. And I'm talking about Dr. Wren because Dr. Wren's going to introduce today's speaker, and I'll stop for now and we'll continue.
Excellent. Thank you so much for having me back. I will just take a couple of minutes, but I'm pleased to present this in my capacity from the Integrated Care Training Program. And so as Joe mentioned, I want to share some local context around our development of a pathway for what we're calling a baccalaureate level behavioral health support specialist, or a BHSS, that we're working on here in Washington State. And so just quickly, this work is being done in tandem, of course, with ICTP, and specifically in the department with Pat Arian, with Anna Rotzliff, and with Patrick Rowie. And so the four of us, as well as some dedicated staff, have been trying to champion this and had some early connections with Professor Farrand, who I'll introduce momentarily, because he's really led this work in England with the National Health Services. So just briefly, what we're trying to replicate here truly is inspired by the IAPT model that Professor Farrand will present to you. And what we're trying to pioneer is what we're calling this behavioral health support specialist role. And so this is a bachelor's level, perhaps non-specialist position that we developed, or we are developing, to increase access to evidence-based behavioral health care in primary care specifically as a first target. And this position is created by both training and then credentialing, ideally, this sort of a BHSS role. And this person would be equipped to develop low-intensity interventions. This is exactly what Professor Farrand will be presenting on. And our target here is common mental health disorders in primary care. So typically mild to moderate depression and anxiety. And this is being done in our model in a stepped care fashion, where of course more acute or complex cases could be referred on to specialty providers. And so here at UW, we're very much in the development stage of this. I just want to briefly show you how we're thinking about this development. So we are thinking about these three buckets of education, industry partners, and then policy to ultimately bring this to fruition. So with regards to educational partnerships, we have done some pilot coursework here at the University of Washington in the Department of Psychology. We've had some good success training undergraduate students in these low intensity interventions and actually developing them and delivering them with patient participants. Most recently, what we're doing this semester, this quarter, so to speak, is partnering with Eastern Washington University. So thinking about the power of this role to increase access in rural parts of our state. So EWU has launched a certificate program where they're actually training undergraduate students in a certificate course in some of this pilot curriculum that we've developed through ICTP. And we're hoping to expand this with other educational partners. So the second bucket being industry partners. Just really quickly, we did hear some stakeholder assessment of different educational and clinical and administrative partners across Washington State to see how they thought about the acceptability and feasibility of this role. And we had some pretty good feedback that we're actively working on. We've developed some core competencies to really sink our teeth into what this role would actually look like. And then other engagement is we're both kind of actively working with other stakeholder groups that are addressing behavioral health workforce needs broadly across Washington. We've invited a lot of them here today, so I hope that they're able to hear Professor Ferrand's presentation. And then we're currently developing practica or field experience opportunities for these students and what it would mean to have a bachelor level individual delivering interventions and what those supervision needs would be. And then finally, policy is going to be the big piece that we continue to chip away on. And of course, COVID and budget needs have sort of put some of this on hold with emerging priorities, but this is sort of our long-term goal, is how can we move policy to actually credential this sort of a role in Washington state so that this person can be sort of legitimately and has some standardization around their training and around their role, and also open that up to billing. So with that, I'm so pleased to present Professor Paul Ferrand. And so he's coming to us, I believe it's 8 o'clock where he is, but he's coming to us. He's the director of the portfolio in low intensity cognitive behavioral therapy. And he's in the Clinical Education Development and Research, or CEDAR Center of Psychology at the University of Exeter. So he's coming to us from England. And so Paul leads a research group, training and development in low intensity CBT. He manages a team of 8 researchers, 25 clinician educators, has trained over 250 students, and undertakes research and consultancy, both here with us, but then also more long-term at the University of Wisconsin and an Uppsala University in Sweden. He's edited leading books in low intensity cognitive behavioral therapy, addressing the theoretical background, and leads the training text and written many of the most commonly adopted low intensity CBT written interventions. And so these have been implemented in the IAPT program. We're using this book that I show really to anchor our conceptualization of what a BHSS provider might deliver. Paul is a member of the expert advisory group for the IAPT program. He'll talk about what IAPT is through the National Health Services Psychological Professions Network, which is leading the development of this emerging psychological practitioner workforce. And this represents low intensity CBT within the British Psychological Society, and newly appointed associate editor of the Cognitive Behavioral Therapist. But clinically, Paul works as a consultant psychological therapist lead with the head and neck specialty at the Royal Devon and Exeter Hospital. So thank you so much, Professor Ferrand, for sharing your expertise with us today. I'll stop sharing my screen and I'll turn this over to you to share your work coming out of England.
Okay. Am I all set?
You're ready to share, yes.
Yep. Oh, I need to share again, do I?
Please.
Ooh. Is that all good?
Yes, that's good. Thank you.
Okay. Well, thank you for inviting me to this. It's something I'm passionate about, and I'm so thrilled to hear that your state is thinking along these lines, because I honestly think this is a solution to the current situation that many countries find themselves in regarding mental health. I am in Britain, so if you start seeing things get slightly darker, it's because it's getting darker just out the window there. Well, hopefully you'll find this interesting, and there'll be time for questions at the end. Let me just start that now. Okay. So why do we need to think about doing things differently in mental health care? Well, hopefully you can see some reasons why we need to, because quite simply, mental health care is a public health challenge, and it's not working in many, many countries. We've actually got it working in England, and hopefully that's what I'll start giving you a little bit more understanding about. Firstly, we can't forget mental health problems are prevalent and they're highly disabling. So from a patient's perspective, from a personal perspective, we need to sort it out. We need to give it as much attention as physical health care does. The problem is the majority of common mental health problems are unrecognized and untreated. And obviously we've got the treatment gap, the difference between the people getting evidence-based psychological therapy and the number of people who have them. And for GAD, I think it's about 75% of people who have generalized anxiety disorder aren't receiving an evidence-based psychological therapy. Quite frankly, it's not good enough. And the treatment of choice in many countries is medication. Now, there's nothing wrong with antidepressant medication at all. It's evidence-based. However, there should be a choice for patients as to whether they want to take medication or whether they want to use psychological therapies. The reality is that actually most people end up using both anyway, but it's the choice element. And then finally, waiting times for a psychological therapy can be excessive. In some parts of England, before IAPT came along, people could wait 14 months for treatment for a common mental health problem. Once again, it's completely unacceptable. It's a system that's broke. And if it's breaking, it needs fixing. So the solution is the IAPT program, and the problems were the waiting lists, lack of choice, services being too expensive. If we can reduce the price of services, then you can actually have more service for the same price. And often the interventions weren't acceptable. So it's about choice. And once again, if you offer patients choice and they choose the one that they think will fit better, it's also more likely to be effective. So you've got that benefit as well. So in essence, we needed a revolution and not an evolution in mental health. What's very clear in mental health is it's evolved. It's been evolving for 50, 60, 70 years. But unfortunately, it's never solved the problems of waiting lists, limited choice. So we needed the revolution. And the revolution was the way in which psychological therapy is organized and delivered. Because one thing you'll hopefully appreciate is this isn't just about delivering a new psychological therapy. This is about establishing an entire new organization of care. So the revolution is the improving access to psychological therapies therapy service program. It's been going for about 13 years in England. I was there at the very beginning of it. I remember being sat in some of the most heated battles I've been in. And interestingly, when you were talking about some professional bodies, etc., this is where some of the implementation challenges tend to be faced, but we've got through that now. At the essence of the Improving Access to Psychological Therapies program is evidence-based practice. In this country, we have the NICE guidelines. I'm not sure how common they are in your country, but basically, series of experts look at the evidence, they chuck out the rubbish, and unfortunately, they still chuck out a fair bit of rubbish. They get the very best high quality studies, and then they make recommendations made on those. So that's the evidence base at the core. The UK government has invested over £1 billion, and it's invested in a workforce of nearly 11,000 practitioners, evidence-based practitioners. And in terms of the workforce, 40% is low intensity, which I'll talk about later on, and 60% is high intensity. And high intensity is what you guys probably know a little bit more commonly as CBT. It's face-to-face, delivered over the therapeutic hour, according to guidelines, 16 to 20 sessions for depression. So what you commonly conceive as CBT, we call high intensity now. I'm going to focus more on the low intensity workforce. Now let's look at if IAPT is working, because it's always good. I'm talking about a model, which I'm very passionate about, but let's just see what it's done over the 11 years. So in 2019-20, we had 1.7 million referrals, and that was up on the previous year from 1.6. 87% of patients started treatment within 6 weeks. So we've gone from 12 months down to 6 weeks, quite an achievement. We had 1.2 million referrals that started treatment, and that was up previous year to 7%. Now this will be interesting. Average treatment sessions were about 7. If we think of the NICE guidelines for depression, the recommendation is around 16 to 20. So we're seeing a massive drop in the number of sessions are needed to reach recovery for patients. And you'll see that's all part of the step care model, and that's all part of having these different workforces to deliver treatment at the right severity, at the right dose for the right severity. We had about 600,000 referrals, completed a course of treatment in that year, and 51% of referrals moved to recovery. Interestingly, this is a slight COVID. Because of COVID, we had a slight dip. We were achieving 52%. But that's not a great loss, which some mental health services would have experienced. And in COVID, because of the way we work, actually our service closed down for 2 weeks, and then we were fully back working, fully operationally, given the use of digital technologies and video conferencing. Now, how did we get the government interested in IAPT? Quite simply, it was to do with money. Probably the same in your with the NHS. The government and the government of the day, and it was a Labour government at the time, and the Conservative government are still fully backing. The reason why is we made a business case. We said, if you invest this amount of money in mental health, we'll reduce the number of people who are on incapacity benefit in this country. If you're off ill for a medical, psychological problem, you get benefits paid. So we can, if you invest the money in mental health services, we will actually get people back to work. So we'll reduce the incapacity benefits that the government is having to pay out, and will increase productivity at work. So we'll reduce presenteeism as well, and productivity will increase. And as you can see, in terms of this metric, it is a bit old because they're only updating these metrics at about every 10 years. Over the years until 2012, you'll see the number of people who have moved off sick pay and benefits. So we have a system that, because of our national health system and the government investment, actually it's cost neutral. The benefit is it's not costing anything to the economy because of the increased productivity, because of the reduced sick pay benefits, but equally patients, millions of patients, are getting an evidence-based psychological therapy service. So patients are benefiting, society is benefiting, and the economy and the government are not spending any more money. And that's a real bottom line of the Improving Access to Psychological Therapies programme. As you guys may say, it's giving you more bang for your buck. So we've got three motivators. We've got the economic argument, which I've just made reference to, and you'll see reference to Richard Layard. Richard Layard, and this is how IAPT came about. It wasn't just a number of clinical psychologists in a dusty room devising this. We tried that for years and it didn't work. This was a combination of clinical psychologists, of implementation scientists, of health service researchers, but most importantly, of economists. Lord Richard Layard sits in the House of Lords. He's from the London School of Economics, and basically he did all the hard grafting around the numbers. And he made the cogent case to, at that time, the Labour government, which firstly set up the IAPT programme, moved to a Conservative government, and they've been wholeheartedly supporting it. So we've got the economic argument, made it a lot easier to sell. We have the evidence-based NICE guidelines, and I've listed them all there, and they cover generalised anxiety disorder, panic disorder, depression, etc. And we know that when we're having low intensity and high intensity, the NICE guidelines say there's an evidence base behind low intensity and high intensity. And finally, I mentioned about this not just being about psychological therapies, we have step care. This is the organisation of care, and this is fundamental. We are completely revolutionising the way we're delivering psychological therapies. And I'll talk a little bit more about stepped care. So stepped care really is the solution to unmet demand. It's when your implementation scientists, your health service researchers come to the fore, the ones who organise services and say, let's organise this different. Now, I'm not sure if I had to give a talk many, many years ago to a group of general practitioners who were a bit unhappy about this because they didn't like this idea of a practitioner workforce. They saw it as dumbing down. So because I'm particularly resilient in some contexts, I had to go and deal with a group of hostile primary care physicians, general practitioners. Now, the simple thing is, step care is borrowing from the medical model. If you have a physical health complaint, actually the first thing you don't do is run into a hospital. You go off, unless you have to. If it's an emergency, obviously you will do. But predominantly you'll go to your general practitioner and you'll have an assessment, and your general practitioner may be able to assess the problem, and they may be able to treat it with a low intensity treatment. Medication generally is a low intensity treatment. If someone has a problem with their gait or their movement, maybe all they need is an orthoptic device, a low intensity treatment. Or they may, so the general practitioner, and remember the title practitioner because we'll come back to that, is your low intensity therapist. They're delivering a low intensity dose of treatment to the patient that they can work with. Now, this is when we have the stepped care model. If the GP assesses someone who may need more investigation and then a more thorough assessment, and then may need more intensive, a bigger dose of psychological therapy, then they get stepped up to high intensity treatment. So this is where your CBT therapists or your other evidence-based therapists would come in. 16 to 20 sessions for depression as evidence-based in NICE guidelines. So they do longer assessments, they do longer treatment sessions of an hour, whereas a GP session may be 5 or 10 minutes, and they work with patients for longer. And then at the highest tier is your severe inpatient cases. These are your severe and enduring cases. Maybe they need to be sectioned and go into an inpatient care. They may have high levels of risk. So when we're talking about something very clever in mental health, physical health care, I've used the step care model for many, many, many years. So we're not doing anything really that revolutionary. We're just following what the medics are doing, have done for years. Now, NICE recommends the delivery of mental health within a step care model. So it's a recommendation that NICE has made around how we organise care. And basically, as I've made reference, treatment is provided, evidence-based treatment is provided at the appropriate level to meet the severity or the impact of the patient's mental health problem. So we categorise patients into mild to moderate, moderate or moderately severe or severe. And then we make decisions based on the categorisation of mild, moderate, severe. So that's what dictates generally, there's some exceptions, but generally as to what step in the step care model they go into. It's all evidence-based, and patients must be able to progress through the step care model. If they become more severe, then they should be stepped up. If they become less severe early in treatment, they may benefit from being stepped down. So treatment can continue with low intensity from someone who may actually have started at higher intensity. Obviously, if risk starts to emerge, then they can be stepped right up. We have different staff. We don't have one staff that does it all. We have different staff at different levels, and they have different levels of responsibility, and they have different competency-based training, and they possess different competencies. But before we go into, this is the evidence-based step care model. At step one, this is community, watchful waiting. It may be assessment, and it's very much about recognizing the problem or making use of the range of community resources there are. If someone is suitable for a low intensity service, which is at step two, the evidence suggests mild to moderate depression, mild to moderate panic, or generalized anxiety or obsessive compulsive disorder. That's where the evidence base for low intensity resides. And then what we have is, in terms of the interventions, we have computerized CBT, guided self-help, behavioral activation, which is seen as separate from CBT as well. So we're talking about the more behavioral orientated rather than combined with cognitive therapy. And then for depression, we also have exercise. It's been changed now to physical activity rather than exercise, for good reason. So we have that range of low intensity, and then at high intensity, you'll see CBT and behavioral couples therapy, where there's the evidence base. One of the things to point out is social phobia and post-traumatic stress disorder. There is no evidence base at low intensity. So if someone's assessed and they have PTSD or social, they immediately go into step 3. They don't have to go through step 2. So fundamentally, what I'm going to talk about is the step 2 low intensity service. Now let's just look at some of the differences between high and low intensity, because this causes a lot of people a lot of confusion. And a lot of people are still trying to get their head around this. And what they think is low intensity is actually not low intensity. Sometimes people say to me, well, it's just brief CBT. Actually, it's not brief CBT, and it's as far away from brief CBT as you can possibly get. Now, I'll elaborate on that in a second, but fundamentally, low intensity CBT is predominantly focused on the here and now, on the presenting problem. So the assessment would be, what is bringing you to my clinic today? What are you struggling with? And then they will use very much the Podesky or the 5 areas model to understand the problem that's presenting in terms of thoughts and behaviors and emotions and physical consequences. What they don't do is they don't do what high intensity therapists do, look at rules for living, attitudes or assumptions, or they don't look at core beliefs. So one of the differences is the assessment. Here and now, low intensity, high intensity assessment includes these other levels of cognitive distortions at the intermediate and the core belief level. So immediately we're reducing the amount of time people are being assessed. So that time frame reduces. So let's look at the differences here. Therapeutic dose. Low intensity have briefer and fewer sessions. High intensity have longer sessions determined by NICE guidelines. Formulation, low intensity here and now. High intensity is longitudinal. So you do look at core belief work. You do developmental formulations. The specific factors that PWP, that low intensity will be used is very much the funneling to inform the ABC model. So the specific factors are reduced as well. High intensity will use techniques such as downward arrow, continuum, schema focused therapy. That is certainly not low intensity. Interventions are single strand. High intensity therapists, if you're working with depression, you may start with behavioral activation, but then you may use some cognitive restructuring, and then you may use some problem solving. In low intensity, it's not that you identify the best single intervention to use. For depression, you would predominantly tend to veer towards behavioral activation if the patient was willing to work in that way, because that's where the best evidence is. But what's interesting about low intensity is you use one intervention. If that intervention hasn't worked, then there's a good chance you'll step someone up to high intensity therapy. The role, low intensity, it's a practitioner role. High intensity is a therapist role. But there's no difference in terms of making independent treatment decisions. Oh, let me just turn that off. They both make independent treatment decisions. So they're both professionals in their own right. Low intensity has something called case management and clinical skills supervision, which I think is fundamental. High intensity generally just have clinical skills. So you'll see these are fundamentally very different. It is not brief CBT. I was on a call to Israel and they thought they were doing it because they were doing brief CBT. In my understanding, brief CBT is like your Premier League footballers who know what corners to cut so they can get to the essence of the problem. They can treat the problem using high intensity techniques in a much reduced number of sessions. That is not what low intensity is. So let's look at what low intensity is. It's the delivery of CBT in a manner that aims to use health technologies to enable the patient to work in a more self-directed fashion at their own pace and within their own time. And they come in a number of different formats: books, manuals, audio. There's some audio-based CBT self-help materials, and digitally enabled. Interestingly, in this country, digitally enabled self-help is massively underutilized. It's a problem. And I'm going to be picking up on some of this a bit later on in terms of mobile CBT, because given where you come from, you're perfectly well pitched to start thinking about some of these areas and enhancing your digital offering, because we have a range of issues in this country in what we're using and some resistance to using it. And if I'm honest, I think it's more where IAPT needs to go. Low intensity CBT places reduced demands and costs on service providers. We don't have a one-size-fits-all workforce. We have a different workforce who are on different pay scales because they have different responsibilities. And the low intensity workforce see far more patients than your high intensity workforce because they work in briefer time periods, etc. And whilst we reduce the time the practitioner is in contact with the patient, some very good research from Annemieke van Straten at in Amsterdam, Free University, actually said the therapeutic dose was the same as that experienced in high intensity CBT. Because in high intensity CBT, the patient does homework, but relies a lot more on the therapeutic hour. In low intensity, where the resources and the interventions have been delivered to be used on their own, have been developed to be used on their own, the patient engages with them more on their own. So actually, whilst the cost of delivering is much reduced in low intensity, the dose is received is actually the same. And we know there is a dose effectiveness relationship. So that potentially accounts for the evidence base. Low intensity is flexible in the support format. So we have a bespoke psychological wellbeing practitioner workforce that delivers low intensity CBT. And they deliver to a national curriculum that I was partly involved in writing and developing. The characteristics of low intensity CBT is based on flexibility. It reduces the demand and it therefore increases access for patients. So it reduces demands placed on the service, who can then use that money to improve access. Support can be offered face-to-face, telephone, by email, but that's not really being embedded either. So that's far less used. If you want to look at the use of email support, then look for places of Sweden, which are using that a lot. In terms of reduced time, an assessment at low intensity is 35 to 40 minutes. And then it's regular 20 to 25 minute support sessions. So you can all of a sudden see where the efficiencies are coming in. Some people initially during the early days of IAPT said, well, this is very good, but it's providing therapy on the cheap. So we had to demonstrate that, yes, it is providing therapy on the cheap, but it works. As of 2018, there's over 30 systematic reviews and 50 controlled trials that have demonstrated the effectiveness of CBT self-help, and also demonstrated the effectiveness of computerized CBT through the range of platforms that exist. So that's just some examples. If you go to the Delgadillo original paper, they list them all. Now this is interesting. Pim Kuipers and his colleagues in Free University and in Stockholm, I compared face-to-face with self-help. And the results in a systematic review, and as you'll see in the highlighted section, the comparison between guided self-help and face-to-face psychological therapy at post-test was effect size 0.02, nothing really, but in favour of guided self-help. At follow-up, up to 1 year, no significant difference. So we've got no reason to assume, if you follow the right protocols as to where people enter the step care model, we have no reason to assume we're delivering therapy on the cheap. We're actually just, and it's being less effective, we're just delivering it on the cheap where it's appropriate to do that. Let's look at the workforce, the PWP workforce. Why do we need PWPs? In this country, we had the biggest workforce was the most expensive, the clinical psychologists, but predominantly they dealt with the smallest number of patients who had the severe and enduring mental health problems. What we had there also was the smaller number of staff to deal with the mild to moderate. So what happened was we turned this on the head, or we're turning this on the head, and we've invested very heavily in the psychological well-being practitioners to deal with where there's the greatest demand. And I think we're beginning to see a decrease in clinical psychologists to match the demand for severe and enduring. So it's putting the resources where the resources are needed. PWPs, I've mentioned this, they're independent practitioners. They make their own decisions. They don't need to look at other professionals to make the decisions. However, they do have a form of supervision, case management, which I'll talk about in a second, which helps them and manages their caseloads. And it brings efficiency into the step care system, and it ensures safety as well. PWPs don't have to have a professional background, but they are registered with the British Psychological Society and now also the British Association of Behavioural and Cognitive Psychotherapy. So they can go either the psychology or the therapy role. They're trained to a national curriculum, which I was originally involved in the first revision of, in the first version of that. And this is the basis of the course accreditation and the PWP registration. So we have a set curriculum which is delivered across the whole country, and we ensure the universities deliver to that curriculum. If they don't do it, they lose their ability to offer the training. PWPs are not therapists. They don't use therapeutic use of self in their session. What they do is they support a therapeutic process, and that the therapeutic process is delivered by the CBT self-help interventions. So the interventions have the specific factors, and the therapist and the PWP, the psychological wellbeing practitioner, basically supports the patient engaging with the treatment. The role is seen as that as a coach and engaging in common factors to maintain engagement from the patient with the therapy, with the self-help therapy. The practitioner, however, does use a patient-centered assessment. So they do their own assessments. That's not done by high. The evidence suggests if a high-intensity therapist does the assessment, more people are likely to enter treatment at step 3, because high-intensity therapists will see more complexity where there is not necessary complexity. That's what we've learned. We empirically tested, and that was happening. Where step care didn't work, the step 3 therapists were doing the assessments. Once they've done the assessment, the PWP, they'll reach a shared understanding. They'll administer outcome measures. We use the PHQ-9, the GAD-7, the Work and Social Adjustment Scale. If someone is flagging high on the GAD-7, the generalized anxiety disorder, but a general measure of anxiety, then anxiety disorder specific measures get used on the basis of the assessment and the reached probable diagnosis. The reason why we do it is if you do that and you use disorder specific measures for anxiety, they're more sensitive to the anxiety disorder, and you're more likely to see effectiveness. When a patient is step 2, if a patient isn't step 2 at this point, maybe they have PTSD or social anxiety, they'll immediately get stepped up. If a patient is suitable for step 2, the PWP will use the CBT model to describe the presentation. They'll offer the evidence-based treatments that are available at step 2. They'll introduce the intervention alongside how they can support it, telephone, face-to-face, email, but not commonly used, video conferencing increasingly. And then they'll set the use of the self-help material as homework to review the following week, and they'll see them the following week. In terms of the support session the following week, they'll take weekly outcome measures. It's very important outcome measures are taken weekly. Why? Because your effect size Your effectiveness is a lot higher if you take your weekly outcome measures than if you take pre-post. This is an interesting observation, but what it begins, and it's still empirical, so it's well worth testing, but what it possibly suggests is, or one hypothesis is that when you have dropout, potentially people are dropping out because they feel themselves recovered. So they may not always be dropping out because they don't see the point of carrying on. If it's the case that more people are dropping out because they've woken up one day and say, I feel a lot better, I don't need to go anymore. If you just take pre-post, you've lost that data. If you take it at every session, you've got the last session data, and it may have shown that improvement. So they take weekly outcome measures. As long as you do it properly, patients like it. They like seeing their recovery charted. Their progress on homework is discussed. If they've made progress on the self-help materials, it's reinforced, and then their homework is set for the following week. If progress is not made, the PWP identifies where the problem has been. They apply specific factors. So if they understand they're trained to understand exposure paradigms, for example, they'll identify where the patient has gone wrong in terms of maybe their entry into the exposure hierarchy was too high. So they'll help the patient reevaluate that. They'll help the patient problem solve. They'll set homework. What they will then do is present every case at case management supervision. This is weekly. It's done with an experienced health professional. It's supported through a very big IT system of which every single patient data goes onto. The case management supervisor can look at a screen, can identify what the PWP is working with, and then they engage in a conversation about how they're working with specific cases that jump out. Brings efficiency and safety into the system. And I think it's fundamental. And I think it's one of the very best aspects of the IAPT program. So I've already mentioned about the case management supervision. If you're thinking of bringing IAPT type systems in, fundamentally bring a patient information management system in. It's core. It's core. It makes the services and the therapists accountable. I can sit in the national team and if I want to, I can look at a service and I can say, I'm interested in that therapist or that practitioner, and I'm able to access their data. That's how thoroughly it's undertaken. And that also makes the system transparent. The IAPT program released this data every 3 months. If you go to the web and you look for the IAPT data, you'll see the last quarter data. It's very transparent for all to see. And then clinical skills, once per fortnight, groups of up to 12. That's very much what you'll be more commonly familiar with. Now, there is one interesting aspect of this, and that is low intensity CBT. The evidence suggests it needs to be supported. And I looked at how the evidence may vary by the type of support, because actually there's 2 types of support, and that's guided, and that's very much what IAPT uses. And that's basically, you provide a rationale, you provide regular support around the process issues, and that type of support takes about 25 to 30 minutes. A lot less than high intensity treatment, but still it's a lot higher than minimal contact support. Minimal contact support takes about 5 to 10 minutes. Provide the rationale. It is weekly, but it's non-process orientated. It's basically making sure people are engaging, making sure they're moving forward, and then setting them homework to review at the next session. And then there's self-administered. There's no rationale or support. Patients are just using the interventions, the self-help interventions on their own. Now, both guided and minimal contact, there's very little difference in the effect size. IAPT has gone for guided support. The data suggests that there's actually no difference with minimal contact support. Support is needed because self-administer only gives you a medium effect size. But there's some big issues about support and what constitutes support. And that's what I'm going to move on to in a second. But what we have in this data is very high levels of heterogeneity, massive levels. If you're interested, go to the paper I did with a colleague, Joe Woodford, and it will show you really how dirty this data is. We had different baseline levels of severity. We had different types of support. It was always never clear as to what the support exactly consisted of. We also had another type of support, which we did in a subsequent systematic review, which is due to be published, where it was automated support. So the support was provided through AI or machine learning through systems. But I'll talk about that in a little bit more. But it's moved me on to the next area, really, and that is developments in the clinical method. I've mentioned that IAPT. I've mentioned that partly IAPT is based on new technologies at low intensity CBT. And the PWP role was to put new technologies at its core. Now, originally, when we talk about new technologies, we were talking about CBT self-help interventions specifically developed for the IAPT program, of which I've developed the most commonly used, and they're freely available through the CEDAR website at the University of Exeter. We don't charge, you know, it's the NHS, so we do it for free. But the intention was IAPT was going to spearhead new technologies. And when it talked about new technologies, it was talking about digitally enhanced technologies. So we had a number of computerized CBT systems, but they're not regularly used. It's highly inconsistent, the ones that are used. Some are not low intensity. We have one called Beating the Blues. If you go back to one of the previous areas I talked about in terms of what low and high intensity is, Beating the Blues works on core beliefs. So immediately, it's a high intensity system. It's not low intensity. So we have a lot of issues with the technology. But what I'm particularly interested in is the potential that mobile CBT, mCBT, not CBT, may offer a solution. It can enhance functionality in the here and now, because people are on their phones. And potentially, it can replicate the benefits of support. We know support is beneficial. But can we, with the technology, and I'm pushing this in, obviously, Washington State, because this is where all your high-tech companies exist. These are the world leaders. So maybe you could see what the benefits of support, and can you actually machine learn that and put it through an app? It can further reduce costs of delivery, not get rid of them, but reduce them further, and increase the reach of the psychological therapies further, reach those communities that are very hard to reach otherwise. Now, what we know about mCBT is that most people many patients find these apps acceptable. So we've still got a high level of acceptability towards apps in this area. There are concerns about the quality, security, and the efficacy of mobile apps for depression. And I must admit, I flick through a lot and I'm massively underwhelmed in what's out there at the moment. Because to me, they seem to be a bit opportunistic. They seem to be a collection of evidence-based techniques which are thrown together. And we have a saying is if you throw enough mud at a wall, some of it tends to stick. And at the moment, from the ones I've seen, but I know there's hundreds, I've only seen a few, they're not systematic, they're not evidence-based, they've not gone through a scientific development process. So I have some concerns, but I do think there's a big future. Now, actually, a meta-analysis of 18 studies using mCBT had a moderate effect size. But there was considerable heterogeneity once again in the app content. And there's questions the evidence base. And Leon Flatt recently said to become an asset, mCBT must be well informed, scientifically credible, peer reviewed and evidence based. So if we are going to move this area forward, I think we need that envelope around it. Now, I have worked well, not worked, but a company actually approached me because they were very interested in low intensity CBT. And this is a company, and Iona, I think it's a small company. They're called Iona Mind. And basically they were interested in IAPT. They were interested in single strand, which is consistent. And what they said to me was that they'd looked through the IAPT literature and they were really interested in me in telling them about what low intensity was. Could it go on an IAPT? And then they started to say that they could replicate the benefits of support for low intensity through AI. And they've created this app, I think as a test pace, and it can be, obviously it's free, where they had a chatbot to start delivering the support. There is evidence outside of this company, which now I've got this interest, is Kate Kavanagh starts to say that you can actually use AI to deliver common factors. What we think is so important about the therapeutic relationship, it can actually be delivered through AI, through machine learning. And if we can crack that, then by all means, we can take and revolutionize low intensity. There's ecological momentary assessment, where actually the person is able to use the app and the functionality of the app at the time that they actually need it. So if they notice their stress and anxiety start to inflate, they can start engaging with the app at that moment in time. So really it's taking the therapy to the person, to the time the person needs it. These are some areas around smart personalization. You can tailoring of apps or CBT systems. We know that if you tailor the therapy to the population, it's more likely to be engaged with, it's more likely to be effective. I developed low intensity CBT and engaged it for armed forces veterans. And now it's called a hidden wound service. Low intensity, culturally very acceptable. A lot of armed forces veterans very much like the idea of helping themselves. So low intensity is very, very acceptable to that as a population, and those studies are going very well. Smart personalization is effective in improving outcomes. We know if you use smart personalization. And if I started to understand a bit about this Iona company, the machine learning, they're using it to replicate the support role. So they've identified through their big data that less emotionally expressive users are more likely to benefit from behavioral interventions. So as far as I understand, if someone is identified as less emotionally expressive, their big data highlights that they should be directed towards behavioral rather than cognitive interventions. And the treatment plan in those cases starts with behavioral activation. This is doing exactly what a low intensity or high intensity therapist would do. This is what they've built into their system, as I understand. I'm not an expert in apps or mobile tech, and that's not what I do, but I'm just really impressed with what they're trying to do. So they detect momentary changes and tailor the interventions in terms. And there's growing evidence that these just-in-time interventions go through a process of analyze, learn, and adapt. So you see this machine learning. And they also learn the time of day through machine learning. That patient is more likely to experience changes. And then they can send notifications through the app to actually check in with the patient at that time. So treatment is almost becoming 24/7. So in terms of the digital interventions, we are combining AI to maximize the potential for mobile. And we're facilitating what works for whom, and we're helping to dismantle interventions. So we're identifying, potentially like the brief CBT, the Premier League CBT therapists, we're recognizing and we're able to cut the corners to get to the core of the problem, potentially through AI, rather than having to do the protocolized 16 to 20 sessions. And we have real research potential here, as I see it. The apps can collect big data. I think Iona said they had data on 40,000 users. And if we think I was involved in COBRA, which is one of the biggest gold standard randomized control trial, I think we had 450 and we were all patting each other on the back and congratulating ourselves. I know that was a gold standard study, but potentially getting data from 40,000 people is telling you a lot as well. We can validate the effectiveness for mCBT in clinical practice. This needs to be done. I'm a big fan of where apps can go, although I have yet to see that. But we need to validate the effectiveness. And research should also improve and focus on usability and adherence alongside effectiveness. So we need to broaden the research potential. So I know Washington is a very research active university, as indeed Exeter is. There's lots of research potential in this arena. If you're interested in finding out more, we've got everything, the gold standard, everything you ever want to know about the improving access to psychological therapies is in this manual. Go to it, it gets updated every year by David Clark. So that will tell you everything. These are a couple of the texts I've written. The low intensity CBT is a practitioner's manual. It's very much a training text. The Oxford Guide to Low Intensity CBT Interventions is very much more about the theoretical evidence base behind it. That's my affiliation at CEDA at the University of Exeter, and that's my email address. So if any of you are interested or have any questions for me outside of this, by all means get in touch, drop me an email, and I'll do my best to get back to you. But I hope that's interesting, and I hope that stimulated some questions. I was going to have a break, a Zoom fatigue break, but I got so interested in doing this that I just carried on through. So I hope that was okay with you, Brenna.
Yes, Dr. Friend, thank you. Very, very informative and inspiring. And as you said, an entire new organization of care, not only a new psychotherapy, but a way of matching service to need. We're right at 1 o'clock. So perhaps just for one question related to the higher level of intensity. Perhaps you hear from higher intensity therapists, I see complexity and nuance in patients and believe my patients deserve higher intensity treatment as you've studied. Going along with that, a participant asked, how might you incentivize high intensity clinicians to treat the more severe patients? Perhaps a response in that area.
Okay, well, there's a very quick way, and that's not trying to incentivize the high intensity to treat them. That's trying to incentivize and requiring the services, except if there's obvious reasons not to go to step 2 for the assessment, and then let the low intensity practitioner make the decision as to whether to step them up if they need it or whether to work with them at low intensity. So as far as possible, unless you know a very good reason. So if someone goes to their GP and their GP is very clearly evident the person is struggling with post-traumatic stress, then they should be referred into IAPT directly at step 3. If you're uncertain, they should go to step 2. And then if they can be treated at step 2, they will be. If not, they'll get stepped up to step 3. So once again, it's how the organization is working.
Thank you. I again, very much appreciate you presenting today, especially with the time difference, and for sharing your contact information. I think others will have additional questions and may write to you. I do know Dr. Wren is continuing to work in this area and with you, and we can all use this information as Dr. Wren has pointed out in understanding how this might apply to services in Washington State.
If I can just make an apology, and please let people contact me, because I had my clock starting, but I started at the beginning of my talk. So it came up at 45. I should have started it when you guys were talking. So I apologize most sincerely for that. So please, if anyone wants any questions answered, please use my email there, and I'll more than happily answer them.
Thank you. Also an oversight on my part, but I'm very glad we could hear the entirety of your presentation as well and learn about this. And thank you to the participants for joining us. And thank you again, Dr. Ferran.
No worries. I've enjoyed it, and all the best with your endeavours.
Thank you. Bye.
Cheers, and see ya.